Thank you very much, Jill. Good afternoon, everybody. So this afternoon we're going to look at an infection in diabetic foot, and I managed to beg and borrow my very good friend and colleague Stephen Baxter, who's a vascular surgeon from Southampton. So we're going to do a bit of question and answer, make it a bit interactive for you as well. He only found this out at about 12 o'clock, so bear with us. Okay. Yeah. So introduction-wise, I'm a clinical lead for Solent for a local area here for Southampton, Portsmouth, and I'm going to talk around infection in the diabetic foot. So why is it so critical? Recognising infection in patients with diabetic foot ulceration is really key. The subtle signs of infection can be diminished in a patient with diabetes, and that from the stats point of view, it's a significant risk factor to progressing on to amputation. So clinical outcomes for patients. David Armstrong's found that patients were 11 times more likely to receive a midfoot or higher level amputation for their wound has a positive probe to bone test, and you can see in this patient not necessarily you need to probe to the bone because it's visible. And furthermore, patients with infection and ischemia were nearly 90 times more likely to have an amputation than those patients with less advanced diabetic foot ulceration. So it's a really a significant risk factor in diabetic foot ulceration. So very much for us, it's a team approach, and from an MDT point of view, and that we're like a pit crew that comes around the patient, but to look at how we can manage that, manage that infection, and actually progress that foot on and that patient on to avoid going to surgery. So for me, it's very much around sharing the risk of these patients. So there can be very subtle signs of infection, as is in the top right-hand corner for you, or for significant tissue loss from the patient in the centre here. Stephen, we were doing a talk this morning together. We were looking at second-year medical students, and this patient came up. What was your comment about this patient looking at the tissue loss that's there?
So that rather smelly-looking foot. Obviously, the first metatarsophalangeal joint is open, but if you look carefully, you can see that the hallux on that toe is dusky, and that tells you that the vascular supply to that toe has gone, and that will be caused by deep-seated infection.
Thank you. So for that patient, they went to theatre. The infection was tracking up. They were seen the week before, and the ulcer was the size of a 5-penny piece. So on the Thursday, and this was on the Monday, when the patient pitched in, and he said, "I feel really rough." You could smell him as he walked in, or smell the foot, and so they took out the first and second ray, and most of the tendons going up the medial aspect of the foot, which left quite a longitudinal wound, which did heal. However, functionally, it wasn't a great foot. So actually, after a period of time, he went on to an elective, a planned amputation, which basically turned his life around. So he's a relatively young gentleman. He was in his 30s. He's still a patient for us looking after his other foot. So it's a good outcome for him. So we came up with some questions, looking at the 10 most important questions, and we thought we'd split them into 5. So there's 5 here, and we'll go through and have a little conversation around these, and there's another 5. So the first question was really looking, in which patients with a foot wound should I suspect infection, and how should I classify it? How should I assess a diabetes patient presenting with a foot infection? When and from whom should I request a consultation with a patient with a diabetes foot infection? With patients with a diabetes foot infection, should I admit them, and what criteria should they meet before I discharge them? And then how and when should I obtain a specimen for culture? So if we take the first one, the red flags for a patient. In podiatry, we get a lot of patients ringing up, I'm feeling unwell, I think my foot's infected, and we've got a clear algorithm that we go through for our call centre to identify some key questions. But we were just looking at this, so any diabetic foot patient could present with an infection because they've got an open wound, and then looking at key questions to ask for a patient or a clinician to look at. So we look at increase in discharge, wound bed changes, heat in the foot, previous recurrent infections. Pain in a neuropathic foot is a significant risk identification for an infection. And then feeling unwell. So how many patients do you think sort of feel unwell with a diabetic foot ulcer? This is a debate we had this morning, wasn't it? So what's your views on a systemic infection from what you see coming in through secondary care doors?
I think it can be a bit of a grey sign. I think there are some patients that have horrendous infections that can feel quite well. But if it's a chronic infection, that once they clear the infection, they will find that they actually feel fantastic. So they have slowly been going down a slippery slope, and they don't realize that they don't feel well. So I think it depends whether it's acute or a chronic infection.
And certainly we know with diabetes can mask that immune response. So for a patient who hasn't got diabetes, with having the same infection, they'd be really systemic unwell. They could be a lot more sicker than a patient with diabetes. So, but certainly it's that gut feeling that we all have. You think, actually, this patient I think's got an infection, they need to be somewhere else, or I need to start, and so forth. Clinical diagnosis of an infection in diabetic foot is made on the clinical signs and symptoms, not just the microbiology reports. An open wound will be colonised with organisms, making the positive culture difficult to interpret. So what's your feelings on superficial swabs?
Superficial swabs, I think, personally are great for diagnosing MRSA. Not much more beyond that. I think deep tissue samples, deep tissue swabs, much better. So cleaning the wound and then accessing deep tissue in a sterile way. So get rid of your topical instruments and send deep tissue, whether it's a scraping or a bit of tissue. But a swab across the top of the surface is not really very helpful.
Okay. Yeah, so deeper tissue is the key bit. So the International Working Group on the Diabetic Foot and the Infectious Disease Society of America have come up with a really good table, and that table can be found in the best practice guidelines, wound management in diabetic foot ulcer, that goes through every aspect, and they've got one section on infection. And so from a mild infection, which we probably see predominantly in the community, so it's one or two of the following signs. So local warmth, erythema, local tenderness or pain, induration in the actual area, and purulent discharge. And the table they've given is looks at no infection, grade 1, grade 2, mild infection, grade 3, moderate, and grade 4, severe. So obviously grade 2 being mild, you can manage that with oral antibiotics, empirical antibiotics in keeping with your local guidelines. And then when they're tipping into moderate, those are the ones we probably would see in our MDT or be crossing the threshold into secondary care, because they're going to have a deeper abscess, deeper aspect into the actual foot, but not necessarily any systemic effects. And then looking at the grade 4, which is the severe ones, which are the ones that are traditional ones that are coming in and being managed within a surgical unit or medical unit.
I think from you can have a really severe ulcer in a grade 3 or a grade 2. It's not hugely infected, so they can have a lot of tissue damage. It can look really nasty, but they're not highly infected. But then again, you can have someone with very minor tissue loss who has a grade 4 severe infection with systemic features.
So this is a patient who's well known to both of us, who had toes removed and then had the pressure damage on the actual, because he wasn't wearing his offloading device appropriately. Is that infection tissue damage or pressure, is the question on this one.
Why do you ask me that?
I know.
I'm not 100% certain about that. It could be just tissue damage. I think if things progress quite rapidly, then you would definitely say it's infection. So if things change over the next day or two, it could be that he's got deep-seated sort of necrotizing infection in there. You would have to look at the patient. What is the patient feeling like? What is the tissue around it? If he's got induration or inflammation around that area, then you would swing you towards infection.
Thank you. So this patient presented he was a patient in hospital, and if you look at the wound on the sole of his foot just under his fourth metatarsal, doesn't look too bad, does it? This patient's not the most compliant, quite relatively young, he's only 33, 34, but on examination you can see in between the fourth and fifth toe a stream of pus coming out, and so on pressing on that you could see the wound on the sole of the foot was connecting up to the toes. And there's a little bit of erythema at the base of the foot indicating deep infection there, and certainly around here. So obviously that was a blowout on the side of the foot, in between the toes, the area of least resistance. And management for that was removal of the two toes under Stephen's team. And the gentleman's doing really well. He's practically healed by 4 weeks afterwards. But he was so shocked that, I'm going to lose two toes. But the significant discharge coming out of that area and the fact that you could really milk the pus coming out meant that you needed surgical intervention.
I think this is probably more of a barn door case. We know that the skin itself there's no pathology in the skin. The problem is the pressure between the surface that he's walking on and the underlying bone. So he's got a neuropathic ulcer, so there's pressure down to the bone. And the reason that he's got a blowout or an abscess that's blowing out the front of the foot means that he's got sepsis around that joint. And despite Graham being surprised that he's doing well after the surgery, he required the toes to be cleared.
Yeah. And then what action would we do for this patient where he didn't present with the probe going through his toe? But what structures can you see there? So you're right down to the tendon, aren't you, for this gentleman? So for him, it's an unsalvageable toe. He had osteomyelitis. It was communicating around the actual bone. So deep infection. So needed Stephen's intervention to remove the toe. The 5 next questions are really around on planning, really. Should I initially select and when should I modify an antibiotic regime for diabetes foot infections? When should I consider imaging and what type of imaging should I consider? How should I diagnose and treat osteomyelitis? In patients with diabetes with foot infection, should I consider surgical intervention and what level should that be? And what types of wounds care is indicated post-surgery or post-infection management. So we utilise within podiatry and the diabetic foot 2 tools. So we utilise the Texas tool, which is a grading system, and the B level is the infection, and D is infection and ischemia, and it gives a depth, and it gives a prediction, in essence, of what's going to happen to that foot. And then we use the Simbad score, which gives a prediction of healing. And then you've got the 4 R's, the right organisms, the right antibiotics, the right duration, and the right dose. Certainly our cohort patients, aren't they, Stephen? They're way above 30 BMI plus. So if you're thinking of antibiotic therapy, what sort of recommendations would you consider for somebody who's got a high BMI?
I think taking the patient, individualize their care, look at compliance, are they going to take their 4 times a day? Are they going to take their Fluclox on an empty stomach? Which is, Fluclox is a really difficult antibiotic to manage in community, especially orally. So I think you have to look at what the patient's been on previously from antibiotics from other clinicians. We know that 95% of primary organisms are staph and strep, so we want good gram-positive cover. We don't want to give them a broad spectrum. Unfortunately, a lot of patients tell us that they are pen allergic when they're not, which does make things a little bit more difficult. But good bioavailability, so, short courses.
Okay, thank you. You all probably work to your local antibiotic guidelines, and they're identified by local bugs in your populations locally. So this is the ones we work towards, and very much in keeping with patients with diabetes and the need to ensure that with any infection you want to make sure that you do adequate debridement to start off with to take away any necrotic or diseased tissue. And as you can see from this toe here is you've got a blister coming up on the top. And what sort of level of debridement would you like to see on that, Stephen, from a surgical point of view?
I don't think it has to be from a surgical point of view, but a toe like that I would never send out without at least taking the open, getting rid of that blistered skin off the top. So just the cornified epithelium needs removing. You can then see what the skin is like underneath and make your assessment. But the cornified epithelium of the blister is hiding what's underneath. You want to remove that so that you can assess the skin underneath.
Thank you. So taking as part way through debridement, you can see the extensive tissue loss there. Unfortunately, I didn't get a final picture because he was hemorrhaging quite a lot, so couldn't quite stop the bleeding to take a good picture. But it was really taking away all the tissue as Stephen has described. The aim of debridement is really help optimise the effectiveness of your preparations, allow as deep a sample as possible. So this was a patient in our MDT where our colleague took out the fifth metatarsal head that was diseased and probing down, and to send off from microbiological culture.
I have to say it was already broken. Didn't chew it off or anything.
It was It was just
loose.
Yeah, it was loose. To ensure that you've got a good drainage aspect and observation from a wound bed that you can see. And as you can see from this patient who's got a relatively dry wound on your left, but then taking off that cap, you can see the wound is right down to tendon. I'm pretty sure we're not meant to see tendons, are we, in the foot? But just making sure that you're preparing that wound bed and clearing away as much infected tissue as possible. So cellulitis with ulceration. This is a lady who pitched up, who had worn a pair of shoes and ulcerated under her fifth metatarsal, and you can see the dry plaque that's on the top of the wound that you need to remove. But you can also see the infection tracking into her midfoot and then into her arch. She was a lady who we treated quite aggressively, but getting on top of quite a relatively major infection for her was key. And osteomyelitis. This was a patient who presented with not a healthy toe, and as you can see on the x-ray on your left, and you can see the toe which was communicating from medial to lateral. So removal of the toe, and we're left with a nice wound, or are we? What would be a good management for that patient? What should you be concerned about, if anything? What about the colour of the granulation tissue? Yeah. It's not looking very good, is it? So this was a real sort of growth, like a broccoli head of granulation tissue coming up, and then the importance that we take serial x-rays, and you can see there's osteomyelitis of the fourth metatarsal head, and then some into the fifth. And the plan was for her to go in and have her fifth toe taken off and cleared out. But we aggressively managed her for 6 weeks of clindamycin, 300 milligrams, and it healed. So we managed to save the toe and actually halt the osteomyelitis. So she was very happy, and it was a good result. Not saying that it won't necessarily re-establish itself and come back, because there's always the risk of the osteomyelitis in there can lie dormant or whatever. So Stephen, from a surgical point, I'm trying to catch him out all the time. Yeah, I'm going to owe him so much after this, it's terrible. So this is a patient who presented with a diabetic foot ulcer, and you can see that's the left big toe. Quite extensive necrotic tissue in there. And we certainly like to look at serial x-rays, and there's quite a time frame between these, 6 months. So you can see the one on your left, quite a healthy looking toe, and then the one on your right, the osteomyelitic bones that are in there. And what would your surgical plan for this gentleman be? What would you leave behind, Stephen, on this patient?
There isn't a right answer on that.
Yeah.
So some people would say it would leave the proximal head of the proximal phalanx. You've got a bit of tender attachment. But then you are excising through osteomyelitic bone. So there's a bit of a possibility that you may get recrudescence of infection in that bone segment. So I think you can play it at the time. If the bone is not too bad, feels fairly crispy, someone may leave it. Others will excise it and leave the cartilaginous surface of the first metatarsal head intact, and hope for the best.
Hope for the best. And for this gentleman, not the most compliant gentleman, as most of our diabetic foot patients aren't, but we did get a really good outcome for him. Unfortunately, he's re-ulcerated at other sites. I think he just likes coming back to see us, but it's all footwear, the next ulceration that he had, unfortunately. And that swelling will reduce over time, and footwear or accommodated footwear be really good for this gentleman. So this is a patient who came in on Christmas Eve and had felt her heel crack, or a cracking in her heel. And she was quite a malnourished lady. She was a BMI of 18, I think. And obviously that's not a husband lying horizontal, it's just twisted around the picture, okay? But if you look at the x-ray, you can see she's cracked her heel. So I saw the patient in clinic and rang Stephen and said, help. And he says, I'm on holiday. But you saw this patient just after Christmas. So what was your surgical plan for this?
Yeah. So again, we have to individualize plans. She was a lady, as Graham was saying, malnourished, chronic pancreatitis. She had lots of medical issues, not really ambulant, and she needed sort of damage control. And it was Christmas Day that I took out the top parts of her calcaneum, left the base part so that she had at least a pivot transfer foot.
Thank you. So very much from an infection management point of view, we look at our empirical. We do a lot of empirical stuff, don't we? We go, right, okay, you need to start some antibiotics, and then we will tailor them according to the deep swab results, or keep them on as they are if the swab results come back saying that's okay or inconclusive. So it's really key to know your empirical and your empirical pathway and what's in your antibiotic guidelines. For us locally, and it may be different or may be similar for you, we have flucloxacillin 1 gram QDS and metronidazole 400 milligrams QDS for 7 days. And then if they're penicillin allergic or known to be MRSA, doxycycline and metronidazole. But I would always refer back to your local prescribing committee or local antibiotic guidelines for your local guidance where you work. So the key antibiotics aspect to cover the different types of bacteria, so flucloxacillin, doxycycline, metronidazole and clarithromycin, which we've stopped using so much now because of the number of interactions that clarithromycin has. But certainly from the severe life-threatening aspect, from a secondary care point of view, Stephen, these are your go-to ones. We use a lot of clindamycin as well out in community, don't we, from the MDT. But those ones are pretty standard that you'd choose for those bugs.
Yeah, we don't tend to use doxycycline a lot on the acute infected patient just because it's a bacteriostatic rather than a cidal agent. The Fluclox, as I've mentioned, just compliance is not great, and especially you've got a patient with a big BMI, you have to really hit them with a big dose to get a good bioavailability. And again, speaking secondary care, we tend to have patients that have been on a lot of broad spectrum antibiotics already, and we're sitting in a slightly different situation. But if you've got a compliant patient that's fairly slim, then Fluclox is a good starter.
Thank you. So yeah, so it's key to have that good holistic history. Look at the problem presenting, look at the infection that's there, looking up other comorbidities they've got, looking at the liver and kidney function, looking at any other medicines they're taking over the counter, any allergies, their ability, if they're smokers or they're drinking alcohol, the interaction with metronidazole and so forth, and what will be the general impact of antibiotics on this patient and what your plan is to manage the infection. And very much looking at your antibiotic stewardship is to say, have a good governance approach. Don't use if not necessary. Use the minimum dose, start low, go slow, but an adequate dose and duration. We still see patients who present in our foot clinic who are on 250 milligrams of Fluclox for 5 days, which isn't really, it's a suboptimal dose. Not that they need to have that because of their comorbidities, but it's just that's what was prescribed. So it's really key to get the right dose.
I also think it's worth questioning some of the patients' allergy thoughts, because if they are, had loose stool, they're not allergic to flucloxacillin or penicillins, and that way we can try and keep patients on a narrower spectrum antibiotic. So just making certain that they are really allergic before not prescribing simple antibiotics.
And always follow your local antibiotic guidelines. And so really to sum up from an infection in a diabetic foot, it's really looking at ensuring the patient rests that foot, because if they're walking around on Fluclox, they're not going to get the penetration. Good hydration and good perfusion. Christian's going to talk about the offloading, so I won't steal his lecture. Ensure that you've got that debridement, that's taking away that tissue. Link into good evidence-based wound care to manage it post. But fundamentally looking at good diabetes control, because we know that if somebody, our cohort of patients, they're probably 100 plus on their HbA1c. So to get that improvement in that diabetes control is really key, because if they're really sugary, the bugs are going to really like it. Thank you very much for your attention.